Welcome to Cancer Coach Live. My name is Dr. Ann Partridge, and I'm a professor of medicine at Harvard Medical School and vice chair of medical oncology at the Dana-Farber Cancer Institute in Boston. Today's program is A Woman's Role in Her Breast Cancer Care, presented in collaboration with Susan G. Komen. I'm joined by Rebecca Segal-Coyle, a 10-year breast cancer survivor, and Christina Broussard, an education and patient support manager with the Mission Department of Susan G. Komen. We'd like to hear from you during this program, so please take a moment to ask your questions. Just type them into the box below at any time during the discussion. Please keep in mind that the questions should be general in nature. We are unable to answer questions about your particular situation, but we encourage you to bring those questions to your doctor. Today's program will cover topics that are important to know, from understanding breast cancer basics to understanding your diagnosis and establishing the right care. During the program today, we also have the opportunity to view interviews from Barbara, Christine, and Sheila, 3 women living with breast cancer, and hear about their personal experiences. Let's start by hearing from some patients, Barbara, Christine, and Sheila, as they share their experiences finding out their tumor type.
My breast cancer type the first time was invasive ductal carcinoma 2B. I found out the first time about that it was invasive ductal carcinoma when they did the biopsy, but when after the surgery that they did the analysis, the pathological analysis, then we know that I had one positive node under the arm, and also that it was 2B because of the number of nodes involved and the size of the tumor. So my surgeon at the time explained to me the details of what it meant based on the pathology.
My breast cancer subtype is triple positive. So I actually have HER2 positive, ER positive, and PR positive. And these are just receptors on the breast cancer cell that you can actually target to manage and hopefully eradicate. And I found this out after we had to do a biopsy. And I learned from the biopsy, I learned what subtype I had. And I was also able to see actually almost like the percentage of how highly expressed these different receptors were.
Let me tell you a little back history. My mom died of breast cancer in 2004. She was diagnosed in 2001, so she only lived 3 years with metastatic breast cancer that had spread to her liver and ribs. 5 years later, in 2009, I received a diagnosis of metastatic breast cancer. Tell me, what I need to know to continue to live. And she said, well, you have estrogen positive, which is HER2 positive, ER/PR positive breast cancer. She explained it to me. She explained it, the difference between triple negative. And I was like, oh my God, I just never knew that this is that many breast cancers, because still to this day, I don't know what type of breast cancer my mom had. So then they sent me over and I had the BRCA, and the BRCA was negative. And I'm like, who knew genetic testing, or I could have had that done earlier, even though it may have still come out negative. And, my oncologist, for the past 10 years, she has just been hands-on.
Rebecca, how were you diagnosed, and how similar or dissimilar was your experience at diagnosis from those patients we just heard from?
Thanks, Anne, for asking. I was diagnosed by finding a lump myself, and I went to my doctor and told her about it. And it started the process of going through getting a mammogram, which I had to push forward given I was 35 at the time, and then a biopsy.
And how was that experience for you in terms of when you first heard you had breast cancer? Did you turn to anybody in particular, family, friends, healthcare providers? Who did you hear it from?
I actually heard, from my nurse who had called me, she was the one who actually said I had cancer. And actually, I actually had to say those words instead of her, meaning she called me and she said, your results are positive. And I said, are you telling me I have cancer? And she said, yes. So I turned to my family because I have a family history of breast cancer, and I leaned on them for support.
And you're quite young, so you weren't getting breast cancer screening, I would imagine.
No, I was 35 years old at the time. And actually, when I originally found the lump, I was 34, went to my gynecologist because that was the only doctor I had at the time. And she said women my age get lumps all the time, and she wasn't concerned about it. So I waited a bit. And then as I noticed that the lump was growing, I decided to find another doctor who would listen to my symptoms.
Sounds like a wise decision, not that uncommon, particularly among our young patients. Thank you, Rebecca. So after hearing Rebecca's and the other patients' stories, let's take a step back and talk about the basics of breast cancer. What is breast cancer? Breast cancer is uncontrolled growth of breast cells. Some breast cancers are a result of mutations in genes that regulate the growth of cells. It's pretty much all breast cancers. It's a malignant tumor if it's called cancer, but there are several types, and some are more malignant or bad than others. It can occur in the ducts of the breast or the lobules. The ducts are the pathways by which milk historically in a nursing mom would go from the lobules where the milk is made to the nipple. Invasive means it's invading beyond that duct. It's going outside of that duct, and the tumor cells are able to bounce through or push through the membrane. And non-invasive means they're staying in the duct or the lobule. It also can be clinical appearance that helps with the diagnosis. And then, of course, we also look at what the receptor status is of a tumor and then the tumor molecular profile. All of these things play into what breast cancer is and whether it's truly a malignant cancer or tumor, or there are non-malignant tumors as well. It can get a little confusing. And there's a conventional pathway to diagnosis. You heard some of them from our patients that were helpful enough to share their stories. A clinical breast exam, physical exam, is often a way a woman it presents with a lump. Either a provider finds it, or more commonly, a woman would say, hey, I've had this lump, what do you think, or calls. The likelihood of a lump being something more than a benign process, a non-malignant process, depends on a woman's own medical and family history, so her own personal history. But generally, a lump in a postmenopausal woman, you worry about its cancer till proven otherwise. In a premenopausal woman, like you heard from Rebecca, a lot of young women get lumps and most of them aren't cancer. So it can be a little bit of a dilemma. And so we can watch them a little bit unless it has suspicious characteristics. But that being said, you don't watch for too long, and you often will do an image just to make sure it doesn't have any suspicious characteristics. What are those images that you can do? Well, there's screening mammogram, or in a person with a lump, it's a diagnostic mammogram. Screening means asymptomatic. You're just doing a screening to make sure there's nothing going on in a person who has no symptoms or problems. Diagnostic means you have a lump or you're following something from a prior study or some other symptom. What other imaging tests do we use, particularly in our younger patients or in the lump setting? We do ultrasounds of the breast and we do MRIs for imaging. And then if there's enough of a suspicion to say, hey, I can't be convinced that this is totally not malignant, it's really benign. If you're a little worried, sometimes we watch. And then about 1 in 4 times of a screening test, we'll end up doing a biopsy because we see something that's suspicious enough. And those biopsies typically are a core needle biopsy. Occasionally, if you think it might be a cyst and you're not sure, you'll do a finer needle biopsy. So core is bigger than a fine needle, and you aspirate maybe fluid and just make sure that fluid is benign, and maybe the cyst goes away and it's nothing, which we see a lot in young people. Or if it doesn't go away, or the fluid is, there could be a mass next to a cyst, or if the fluid's bloody and we send it for cytology to look at the cells in the fluid, sometimes that can have something more insidious than you would have expected. It may not be benign. And then sometimes we have to do a surgical biopsy because you just can't get at it with either a core or a fine needle. And that pathology report is the key, though. So if you pull any fluid out or you pull any tumor out, any tissue out, that will automatically be sent by whoever did the procedure to the pathology department at the hospital or cancer center. And that's the money. That's the most important thing. What does it show under the microscope with special tests to look at those cells? And that's what comes out in the pathology report. So we'll get back to the pathology report, but let's talk about once someone is found to have in that pathology report cancer, breast cancer specifically, how do we stage women? And or men, because men do get breast cancer. And everybody should talk to their doctor to find out what their stage of breast cancer is and how it might influence their treatment options. It used to be 20 years ago when I first started doing this, stage was king. You knew your stage, you knew your treatment. It was, you got it in your nose, you need chemo, you don't, you may not. It was really very kind of simple. It was easier then, but it wasn't good for patients. Now we have a much more nuanced approach, and stage is just one piece, an important piece that predicts how people do, and to some degree, which treatment is most appropriate. Stage is about where the cancer is. Is it just in the breast, or has it moved into the lymph nodes, or is it somewhere else in the body? That's basically stage. And there are other ways, though, that we talk about how to choose treatment beyond stage, which I'll get to, but let's first talk about stage. So clinical stage is when a person comes in and they are examined by a doctor or they get imaging because you want to get more in the breast or elsewhere in the body. And that's, it's cancer because you've had a biopsy, and then you get a sense of, well, how far do you think it's traveled? Is it just in the breast? Is there a palpable problem under the lymph nodes and the axilla, or is the person having back pain that you got an image and you're suspicious something's going on in the back, right? Hopefully not for most people, but for anybody. But that's how you stage people clinically. It involves the size of the tumor, the lymph node status, and then whether or not it's spread. And you can see the TN and M system is what we use typically. These days, there's actually a newer staging where we include things like grade and receptors and some genomic tests, which are not available everywhere in the world, but in the United States are often available. So the staging has changed, but conventionally we think about it as amount of cancer, and then that predicts how a person might do and therefore helps to decide about how much treatment they need. Again, that is evolving. And that has to do with the tumor testing. So some stage 1 cancers are more risky than other stage 3 cancers if they have more aggressive tumor biology or tumor type. So what does that mean? And shouldn't we all know our tumor type if you have breast cancer? And the answer is absolutely. So what are the hallmarks of tumor testing? There's estrogen receptor, and a tumor can be either estrogen receptor positive, that means receptors are present, or negative. So we call it ER positive or ER negative. Progesterone is another one that we often will test for in most cancers. And similarly, progesterone, another hormone receptor we can test for, is either PR positive, that means the receptors are present, or PR negative. We obviously abbreviate those two as ER and PR positive, and we put them together sometimes and we say HR or hormone receptor positive, because having one or both, we treat that the same in terms of how we think about giving hormonal therapy to treat or not. And then there's HER2 status, and HER2 positive means there's either a lot of HER2 protein or receptor on the surface, and it's not on the slide, but there also is some testing that we can do in the genes of the tumor that will tell us whether there's extra HER2 copies in the genes, whether the genes are amplified for HER2, and that can also be HER2 positive in the absence of the receptor being overexpressed. And so it's a little tricky with HER2 and how we test for it. But HER2 positive means lots of HER2. HER2 negative means some HER2, but not enough to meet the threshold of positive. And that's important because it drives some of the aggressiveness of the cancer, but also it can show us the potential for benefits from anti-HER2 therapy, kind of like ER and PR tell us a bit about the character of the tumor, but more importantly, about the potential benefits of hormone treatments like tamoxifen or the aromatase inhibitor. So these are really important things to know about the character of the tumor, or what one of my colleagues calls it the personality. What's the personality of your tumor? So you got the amount of tumor, and then you got the personality of the tumor that you want to get, and that's the tumor type. What other classifications do we think about? Well, we group these tumor types, and I'm sure many of you are familiar with this. And if you have negative on your estrogen receptor and no progesterone receptor, or very little, and then not larger than a little bit of HER2, then that person's tumor would be considered negative, negative, and negative for ER, PR, and HER2 respectively. And so we call that triple negative. All right. And just, importantly, and researchers know this and doctors know this, that's kind of a wastebasket, because there's a couple, at least, we think at least 6 different types of triple negative breast cancer at a minimum, major types. And so we put that together because they're named by the absence of the receptors, but they're not all the same. And that's an area of active research. Triple positive is the opposite. Hormone receptor positive, so ER and PR, 1, 2, and then HER2 positive, either overexpressed or amplified. That's triple positive. That means you have all the receptors expressed and or testing positive. And then there's gradations in between, which are important. So we have hormone receptor positive, HER2 negative, and then we have hormone receptor negative, HER2 positive. And those are the 4 big buckets of breast cancer that we typically use to help guide treatment. Now, finally, we're increasingly also, as I alluded to, looking into the genes of the tumor. And beyond that, just testing for the HER2, we can also look at other genes. And there's a number of tests that are available. Many will be familiar with the Genomics Health test Oncotype, or there's another test called MammaPrint that's frequently used. And there are others, but those are probably the 2 most common. And we use those in particular to help us to decide whether or not a tumor is more or less aggressive and might warrant more or less aggressive treatment. For example, trying to decide, does this hormone receptor positive, so ER positive, PR positive or negative, HER2 negative tumor, does this person with that tumor need chemotherapy or not? These genomic tests can help us to decide, is this a tumor that mostly would benefit from endocrine therapy and probably doesn't benefit from chemo? Or is this what I like to call a wolf in sheep's clothing? It looks like it should be just hormone sensitive, but should we give the person an extra bit of insurance in terms of risk reduction with the chemotherapy and helping a woman or a man to decide? And to choose between the best treatments, as I just alluded to, those genomic tests can be quite helpful. But it's important to know your own ER, PR, and HER2 status at a minimum to help guide both your risks as well as the options for therapy. And I'm sure your providers have shared that with you. And if they haven't, then you definitely want to know those things about your treatment and to guide your treatment. And so I just alluded to, why is tumor testing important? Treatment decisions are based on the results of these tests being done. They give you information both about prognosis, which is not perfect, to be honest. So sometimes you can get a little bit of a clue about how quickly a cancer can grow and how more likely it might spread. But you really want to know it to help decide about treatment, what makes the most sense, what's worth the bang for the buck, because we know that most of our treatments are not like drinking a glass of water. Otherwise, everybody would just take them and we wouldn't care. There's side effects, there's risks. And so we want to choose treatments judiciously. And you want, for example, I always say to a patient, I don't want to treat a screw with a hammer. I want to treat it with a screwdriver. So if I have a good targeted therapy for you, as opposed to a slash and burn opportunity, I'm going to help you choose that one. Sometimes we need to go with, more than one because a cancer is particularly aggressive or needs the more aggressive approach. So that's how you help make treatment decisions, but you want to be the most informed, both your doctor and you as a patient and an advocate for yourself or your loved ones. So you want to ask your treatment team, where are these tests conducted? How are they conducted? And then you might want more information. And I think if you want more information, obviously listening today is a good idea. And there are very good resources. So I send people to the National Cancer Institute, the NCI, which is cancer.gov. And then I also send people to our leading advocacy organizations like Susan G. Komen. Kristen, do you want to share some of the supports that Komen and others in particular have?
Sure. Thanks, Anne. So the About Breast Cancer section of coma.org has the latest information on breast cancer risk factors, screening, diagnosis, treatment, metastatic breast cancer survivorship, and more. And we actually consider the About Breast Cancer section of coma.org our encyclopedia for all of our educational messages and resources. So all of our information on our site is safe, accurate, current, consistent, and based on evidence. It includes information to help people understand breast cancer, including screening and tumor testing, which Anne just discussed. I'd like to point you to actually 3 resources, which you'll find in the event resources section on the bottom left of your screen. These resources are what is breast cancer screening and follow-up tests, and also breast cancer prognosis. These are actually 3 of our Facts for Life fact sheets, which are a series of over 40 topics in both English and Spanish that can be found on komen.org. So Anne, I'll hand it back over to you to talk about treatment options.
Terrific. Thank you, Kristen. And I would add the Komen website is actually fabulous. And I will say that a lot of my colleagues actually do the reviews, and you guys get some world-class epidemiologists to help with some of the risk factors for breast cancer and things related. So it is a great resource. So thank you for that. All right, let's talk about treatment options. Well, treatment decisions depend on, as I said, the type of breast cancer a patient has, in addition to other factors like the extent of the disease. So type, we're going to say, is both stage and personality or subtype of breast cancer. And then you also have to consider the patient themselves. So how old are they? What's their menopausal status? What's their underlying health status? As well as what are their treatment goals? Now, of course, we all want to live long and well, right? That's a no-brainer, and not suffer. But within that, there's nuance. And that plays out for an individual. So my extreme example of this is you see someone like Rebecca come in, and she's 34 years old at diagnosis. She's not going to look at me, and if I offer her something that has a modest but real benefit, she might take it. She's not going to look at me and say, "Oh, I've lived a good long life. I'm not putting myself through that." Right, Rebecca?
That's right.
Yeah. And so, but you say that you see an 80-year-old and that person might want the therapy. You might, decide with them it's not the best thing, or they may look at you and say that. So obviously you don't make that decision for the patient, but you make sure the patient makes the most well-informed in the context of her or his goals and otherwise health status. So super important to consider the treatment in the context of the human being who has to go through that. And we do that as clinicians. Sometimes we forget it, so you got to remind us. So what are those treatments? Well, from a local standpoint, often a woman is offered a lumpectomy to remove the tumor and some normal tissue around it. It's kind of like a scoop. Thank goodness for the surgeons who know exactly where to go generally, or a mastectomy. And the mastectomy removes the entire breast down to the chest wall, usually leaving the muscle. And so we know from big studies that a lumpectomy followed by radiation is equivalent to a mastectomy in terms of how a woman does in the long run. And these days, they're actually pretty close also in terms of risk of local recurrence. So if a woman has disease where a lumpectomy is achievable, then we'll often counsel her to do a lumpectomy and radiation rather than have to lose her whole breast, because there are some data that suggests that quality of life, at least body image, is better if you get to keep your breast. That's not a choice for everybody, both because of the extent of their disease and or their preferences or other medical reasons. Radiation is done to mop up and kill off any cells that might have been left behind. And sometimes we do need to do radiation even in the setting of a mastectomy. Chemotherapy, in contrast to surgery and radiation, can treat the whole body, just like hormonal therapy, because chemotherapy goes in, usually through the veins, sometimes through the mouth, but it goes everywhere in the body. Hormone therapy also through the mouth, typically everywhere in the body, as opposed to local therapy. So you have local therapy, surgery and radiation, and then you have systemic therapy. And they're called adjuvant therapies if they're anything but the surgery. And the way I think about this is an adjuvant therapy is done. Adjuvant is from the Latin for to help. It's like ayuda in Spanish, if anybody knows their Spanish. And so those adjuvant therapies help the surgery to mop up, hopefully, any cancer cells that might have been left behind, either in the local regional area or elsewhere in the body. Chemotherapy kills or disables those cells elsewhere in the body. Hormonal therapy slows or stops the growth of them. And as I alluded to earlier, you can use those tumor profiling tests to tell you about the genes in the cancer cells. And then we use all this information to try and to help patients to make decisions, right? What other treatment options are there? Well, increasingly, especially for women with advanced disease that has spread elsewhere in the body, we are testing and have shown benefits from what's called targeted therapies in women with both early and advanced breast cancer. A HER2 targeted therapy is the mainstay now. Really exciting progress made both on the early stage setting, meaning stages 1, 2, and sometimes 3, giving really good anti-HER2 therapy and starting to take away some of the chemotherapy. We call that de-escalation. So we've gotten so good with our HER2 treatment that we now can start to say, well, maybe we don't need that much chemotherapy for those HER2 positive breast cancers to help that woman both get rid of her cancer and not have as much toxicities and side effects. And then on the other end of the spectrum, for women with advanced disease, where the name of the game is often control, and hopefully control for a long, happy life, we've got what we call additional therapies that we can do sequentially once a cancer learns to outsmart the drug, which it does sometimes, although increasingly less so in some settings. There are also drugs like CDK4/6 inhibitors, which are targeted therapies used more in the metastatic setting right now, but we're hopeful someday we'll use them more outside of trials in women with earlier disease, and lots of other drugs that have recently shown benefits in women living with metastatic disease, something called PARP inhibitors, and lots of other really cool novel drugs that are becoming available for our patients to help them do better in the long run. Immunotherapy is a new kid on the block in breast cancer. It's been shown in women with certain markers on their tumor in triple negative breast cancer, in particular in the metastatic setting, to be able to help those women to do better in the long run. It's coming to the early stage setting for select patients. Again, seems to be making the most headway in terms of triple negative breast cancer, although I'm hopeful we'll figure out how to get it to work in people with not triple negative breast cancer. The immunotherapy is basically taking the brakes off the immune system, helping the body's own immune system to attack cancer cells. They call it checkpoint inhibitors because our immune system has checkpoints to keep the immune system from attacking ourselves. But it also is keeping our immune system from attacking that bad growing cancer. And so if we can take off the checkpoints and not let it attack a patient, but attack the cancer that's in them, then it can be very effective to control that cancer. And we've seen miraculous breakthroughs in lung cancer and melanoma and increasingly more cancers. And we're starting to see them in breast, which is really exciting. And then finally, there are clinical trials. And I think wouldn't be where we are with all these exciting things I'm talking about today if we didn't have clinical trials. So definitely think about trials. It's not just for people who are at the very end of their rope. Trials I offer to people who have the earliest of breast cancer to try and de-escalate. And sometimes it's to get something different that might be less toxic. And sometimes it's to get something that might be better and better control a cancer or better prevent a treatment. We don't know that it will be better. So you got to go in with your eyes wide open. If we knew it, it wouldn't be being studied right now. It would hopefully be available. So we don't want to be dishonest about that. But talk to your team if the clinical trial is a potential great option for you. They're designed to improve treatment, increase survival, enhance quality of life, avoid toxicity. You may receive a new therapy, a combination, a different dosing. You might get something that's differently targeted for your specific type. And I think it's something that we want to help you to understand the efficacy of new therapies and future generations. But you have to decide it's right for you, obviously. There's a lot of altruism that goes into people participating in clinical trials. If anybody's on a clinical trial who's listening, thank you for doing that, because it's not just about your own treatment. It's about learning for people in the future. So it's giving to go on a trial. And at the same time, hopefully many women who are going into therapeutic trials, many patients are getting some benefit, or at least getting value from the learning that we're doing and the support they need from their teams. Rebecca, I've talked a lot about treatment and all the different options. I hope this doesn't feel too overwhelming to everybody listening. But what kind of treatment did you receive? And want to tell us a little bit about that?
Sure. So based on my age and what we thought was the size of my tumor, we actually started off with a bilateral mastectomy. It just was a good decision, and that surgery was going to give us more information about my tumor type and whether or not I needed future treatment. So after that surgery, it was determined that I was ER positive and HER2 positive. I also had genetic testing during that same time and was also determined that I was BRCA2 positive. So based on my family history, my current risk, and the fact that I did have breast cancer, I went on to have chemotherapy. So I chose to do Taxol and Herceptin.
So you went on one of those de-escalated treatments that we talked about. So we used to give the kitchen sink chemotherapy, which some people still need, with that anti-HER2 therapy, trastuzumab. And then we've recently learned that getting just a little bit of chemotherapy with paclitaxel or Taxol and trastuzumab is good enough for people with not that big of tumors, right?
That's right. And I'll go into this a little bit later, but that was based on my goals. I was offered everything in the kitchen sink, but based on my lifestyle and my goals that I wanted to achieve, I had that conversation with my doctor, and we felt that this was the best route.
Yeah, Rebecca, the BRCA2 status, everybody knows what that is, but I'm just going to say, that's one of the genetic changes that one can test for that does predispose people to get breast cancer. And with a strong family history and you presenting at a young age with, a change, it's not the most common, but it's not uncommon that you would find a BRCA mutation in BRCA2. How did that influence your care, and how did you deal with that?
It kind of helped me realize how aggressive I needed to be with my treatment. Had I not had the BRCA mutation, I might have chosen not to do chemo and do a more watch and wait, or kind of a monitored approach. But given that I had a higher risk of getting breast cancer or even other cancers, I decided to be more aggressive with my treatment, and mostly through my surgeries, because based on that diagnosis too, I also chose to have my ovaries removed, especially given I was hormone receptor positive.
You had the triple positive, as we've alluded to, the triple threat, but you've got very effective therapies, which is great. And I think the good news is that you found out you had the mutation and you decided to be proactive. The vast majority of young and older women will not have a genetic mutation and don't need to do that, and appear to do just as well as if they do. But if a person does have a known hereditary predisposition to breast cancer, like a known BRCA1 or BRCA2 mutation, and there's others we've learned about, their risk of a new primary breast cancer, we think they do just as well with the treatment of the cancer they have, but their risk of a new primary breast cancer is something on the order of 5 to 10 times higher over the next 5 years of getting a new breast cancer in the other breast than your average breast cancer survivor. So most of us do agree with your treatment strategy in terms of the local regional stuff. But it's not right for everybody. And some women do prefer the watch and wait and doing MRIs alternating with mammograms in that setting.
Yeah. So let's go on and ask our audience, do you know your or your loved one's breast cancer type? Select A for hormone receptor positive, HER2 negative. B, hormone receptor positive, HER2 positive. C, hormone receptor negative, HER2 positive. D, triple negative, hormone receptor negative, HER2 negative. Or E, I don't know my type. And you talked a little bit earlier, but where does a person go to find out what their type is?
Yeah, that's a very good question. And folks go to their doctor. That's where they need to go. And the doctor can find it on their oncologist, and their oncologist can find it on the pathology report. And the pathology report makes it very clear. Sometimes there's an extra level of testing that's done, particularly around the HER2. And of course, like all things in nature, there are gray areas. Some people's tumors are kind of hormone receptor positive, and some people's tumors are kind of HER2 positive, but in the indeterminate zone, which makes for sometimes difficult decisions. But for the most part, it's all found in the pathology report, and it's something important to know and discuss with your doctor.
Thanks, Anne and Rebecca. So Anne just talked about treatment options. So let's talk a second about myths and facts about breast cancer. So the first myth says breast cancer surgery and biopsies can cause cancer to spread. So for breast cancer in particular, there's actually no evidence to support this statement. So exposing breast cancer to air during surgery or cutting through the cancer does not actually cause it to spread. Also, surgical and needle biopsies also don't cause breast cancer to spread. So the second myth says, if I take the time to get a second opinion, I will delay treatment and will lead to a bad outcome. In fact, most breast cancers grow slowly enough, so taking the time to meet with several doctors and consider the best approaches to treatment won't affect survival. So experts suggest starting treatment within 60 days of being diagnosed. But, you know, the exact treatment for breast cancer varies from person to person, so guidelines are really there to help ensure high quality care. And these guidelines are based on the latest research and agreement among experts. But it is really important not to delay treatment for too long, especially with later stage cancers or those which are aggressive, like inflammatory breast cancer or triple negative breast cancer, which Anne talked about earlier. However, nearly everyone with breast cancer can take the time they need to consider their options without affecting survival. And, you know, during these COVID times, these second opinions could actually be provided virtually. So the third myth is chemotherapy and radiation therapy does more harm than good. So one of the most important things from the past decades of research on breast cancer is that treating cancers with chemotherapy and radiation therapy saves lives. This doesn't mean that these treatments don't have unpleasant or serious side effects, but the long-term benefits of properly treating breast cancer with chemotherapy and radiation therapy really outweigh the potential harms in many cases. But understanding the benefits and harms of any therapy is really that important, and making those informed treatments with your doctor and discussing those options is really, really important. So I didn't know if Anne or Rebecca had any additional comments on these myths and facts.
No, I think they're important. I don't know if, Rebecca, you came across any of these. I mean, I hear about things like this all the time. Fortunately, most people, you know, the ones I see are coming, right? So they're going to hear from me and hopefully trust. It's hard to I think it's hard when you don't want to hear things, because no one wants to have to take any of these treatments. No one wants to even have to know me. And I often say that to my patients, but I'm glad I'm there if they need someone like me. And I think, you know, we just need to keep supporting people and letting them know that breast cancer isn't a death sentence, but effective therapy can help to make sure of that.
All right, I'll hand it back over to you, Anne.
So thank you. And we're going to have a little panel discussion now, which is my favorite part of these. So Christina, what are some of the challenges around tumor testing that you've heard about that patients face when they're initially diagnosed?
So really, I think the first hurdle to overcome is the normal feelings and reactions of being overwhelmed with a diagnosis. But then once you're diagnosed, there's a whole nother language to learn about breast cancer terminology. So I think the learning curve to learn this language can be a little bit overwhelming. So not only are you navigating the healthcare system, but then you have to learn and understand terms like tumor testing and staging and targeted treatment and hormone positive or negative and HER2 and neoadjuvant chemotherapy. And those are just a few of the terms. So it's likely that you'll find out the terminology sometimes the doctor or clinician uses may actually be a little bit different from even what you read online. So for example, tumor testing may also be called molecular profiling or genomic testing. It's likely most people haven't heard of the term tumor testing before they really needed to know, but the results of this test is really some of the most important information to have when making those treatment decisions with your doctor. So I would just tell people to, ask their doctor what test they recommend, why you need it, and then how the results will be used for your care.
Thank you. And Rebecca, who on your team explained your breast cancer type? And when you first heard about that, what were your initial concerns?
Well, I actually heard it from a couple different people on my team. First, I heard it from my surgeon after my mastectomy. He gave me the pathology report. And then I went over to my oncologist, and she kind of explained exactly what that meant and what my next steps were. And she and the nurse talked about clinical trial options and just kind of giving me some background on how to make the best decision. I think my initial concern was, how much of this is going to impact my life? Given I was 35, I wanted to make sure that I kept living the life that I loved. And while I had cancer, I didn't want cancer to have me. So that was important to make the right decision based on what I wanted my outcomes to be. We also have a couple questions from our audience. Dr. Partridge, do all of these treatments affect fertility, and would they cause hair loss?
Whoa, two different, very, very different questions. Okay, but all mattering. So do all treatments affect fertility? No. The short answer to that is absolutely not. What might affect fertility? Well, you can think about this systematically. Anything affecting the ovaries directly would affect fertility. Let's go to the most basic. Like Rebecca described, she took her ovaries out to prevent future breast cancer and ovarian cancer. That for sure would affect fertility. That's easy. But otherwise, it's a little more nuanced. So the good news is neither surgery nor radiation to the breast, the local therapies, they don't affect fertility. The systemic therapies, our hormonal therapy, like tamoxifen, the aromatase inhibitors, ovarian suppression with a GnRH agonist like Leuprolide or the others that are available, they temporarily affect ovarian function, but it's temporary. They do not hurt a woman's ovaries or impair fertility. But while you're on them, a person shouldn't get pregnant, although sometimes they can, and because it can cause birth defects to be on those oral medications and get pregnant. And then the big deal about fertility when you're on the hormonal agents is that often, as people well know, they're recommended to be received for 5 to 10 years, depending on the risk and the preferences. And during that time, a woman's fertility is waning naturally. It's going down naturally. Chemotherapy does affect fertility. Not all of them, some more than others, but chemotherapy traditionally is the problem for the ovaries. It can affect ovarian function as well as the viability of oocytes, the eggs and the surrounding cells in the ovaries. And so we do have some pretty good estimates about how much chemotherapy affects and specific regimens affect ovarian function as measured by whether people are menstruating. You can also measure surrogates for fertility. There's certain hormones you can measure, like anti-Müllerian hormone. It's not a perfect surrogate, and some women will remain fertile even though they're not menstruating, and other women are menstruating but still not fertile. So if someone's interested in fertility after breast cancer at diagnosis, I get them to the fertility specialist to work with them to try and make sure they don't want to do a fertility preservation strategy and or they understand their risks. Switching gears, hair loss. The good news is that most of our treatments don't cause hair loss except standard chemotherapy, which increasingly we're managing with those new scalp cooling techniques. So not all of them, but many of them can be managed with that. Some of the hormones, particularly the aromatase inhibitors, women can see some hair thinning. I've never seen anybody lose all their hair. So hair loss, I think we're moving away from to a great degree in the chemo world even, but it still is a problem and not everybody can get the scalp cooling. And in some regimens, it doesn't work as well. And these are the hardest things for our youngest patients in particular.
Yes, both of those questions I think are very common and top of mind when you hear those words that you've got cancer. Yeah. One other question. So what treatments are available if my HER2 positive breast cancer has progressed?
So that's an exciting question to answer because that is an area of kind of explosion in the oncology world. And there are several treatments available at different, what we call lines of therapy. So if a person is being treated in the advanced setting, which is usually where we use the words progressed, that person has several, actually 2 new drugs in the past 2 since April that have been approved by our Food and Drug Administration, and 3 since December for HER2-directed therapy. So lots of different new treatments. So we've got, we've got the first thing we think about is trastuzumab, first on the block, revolutionary. We've got pertuzumab, another terrific addition to trastuzumab, especially in the metastatic setting and sometimes in early setting. Then there's a drug called TDM1 that we use a lot, especially at first progression after initial HER2-directed therapy. And then there are a lot of other treatments, including what we call tyrosine kinase inhibitors. That's where you've got lapatinib, neratinib, and tucatinib, the newest kid on the block. Those are used, they're oral, and they can partner with other chemotherapies and anti-HER2 therapies and have made great impacts. And then finally, we're moving more towards the drugs that are more HER2 conjugate type drugs, getting at their antibodies with Trojan horses, kind of like TDM1, but they get in and they get at resistant disease. And increasingly, we're seeing what we call bystander effects, which are helping, because HER2 is like every other subset of breast cancer we talked about. It's also what we call heterogeneous. It's mixed. It's not all one size fits all. And so our treatment, the cancers, unfortunately, can be smart and be smarter than us sometimes, or our treatments are starting to catch up. So that's really exciting.
Great. Well, let's move on to our next section. Lots of great information.
Terrific. Thank you. And now I'll turn this over to Christina, who will start us off in this section focused on establishing the right care. And I emphasize the word right, because what's right for one person may not be right for the other person, but you want to find out what's right for you.
So now we will hear from patients Barbara, Christine, and Sheila. They will share their treatment goals and how they approach treatment discussions and decisions.
It changes as you mature and as you learn more about the condition. But when you're first diagnosed, you really want to see, and I think the goal was really, I want to live. I want to live for my kids. I want to be around. So I was willing to do whatever and wherever because of that. So that my goal was really seeing my kids. And I think I was prepared, and I thought I was prepared emotionally and physically to do so.
In the beginning, I was really just focused on kind of getting through my summer. I wanted to get through my chemotherapy treatments, and then I knew that I would continue on with Herceptin and Perjeta to infusions that I would continue to get indefinitely for the rest of my life every 3 weeks. So I really tried to take everything in bite-sized chunks. It was like, let me just focus right now on chemo. And then, sometimes the doctor would try to talk to me about surgery or radiation. I was like, honestly, I need to just focus on one phase at a time. So my goals were just to kind of get through each phase. And, each different treatment that I had, from chemo to surgery to radiation, carried their own side effects. And I just had to be very vigilant and making sure that I'm communicating mostly with my doctor's nurse, actually, to make sure that nothing that I was experiencing was dangerous, that it was normal, and then hopefully they could provide something to alleviate whatever side effect I had.
She said, "Oh, I got this great clinical trial I want you on. It's working so good." She even said on Tuesday, and she said it's really, really good, working on all my patients. And she said, "Yeah, I truly believe in this, and I believe in her." And, that's how we made our decisions. And my family wasn't too happy about clinical trials because they didn't understand it, Because when you hear clinical trials for the African-American culture, you think of Henrietta Lacks, you think of the Tuskegee Airmen Syphilis Project. And it was like, why are you going on this experimental drug? So it's just like, no, it's not experimental. This is research. This is top-notch research that, the FDA approved, and it's working. It's working on women.
So as we reflect on these really powerful videos, Barbara's goal was to live for her children, and Christine just wanted to make it through the summer while also trying to, take it day by day and manage side effects of treatment. And Sheila was really struggling with enrolling in a clinical trial due to the fear that many in the African American community still feel about experimental research, which was done in the past without consent. So after listening to these women, I'm curious, Rebecca, what were your goals? I know you've kind of talked about them a little bit earlier, but what were your goals when you're discussing treatment with your doctor? And did any of those change? And did you have any challenges along the way?
My personality is actually to be very persistent and determined. So my goal was to not let cancer disrupt my life. I was running throughout the year, and so I wanted to continue running. And I also was working full time. So my goal was really to keep doing those things. The challenges I had were going through chemo and continuing to run. I may not have felt like it, but it really did help some of my side effects and helped my energy.
Thanks, Rebecca. So we just talked about, making treatment decisions with your doctor, but I want to make sure everyone understands there's a lot more people involved in caring for someone with breast cancer. So you're not going to take this trip alone. This slide really provides a picture of what a healthcare team can look like for those going through breast cancer. I think a lot of people just assume that their healthcare team consists of only their doctors, but it's important to see how much more support there is when you cast the net wider. So oncology nurses and other allied health professionals like social workers, therapists, counselors, dietitians, genetic counselors, for example, can provide additional information and support from a different perspective. This net actually is even wider when you include sources of support like support groups and family and loved ones. Some people feel those in their healthcare team are busy or rushed for time, so they may not want to ask questions or just sometimes don't know what to ask. People in your healthcare team are definitely there to offer you information, hope, and advice. So, Rebecca, what can you tell us about your experience with your healthcare team?
Part of how I approached it was I realized I was the CEO of me. I knew myself better than anyone else. And I utilized that to my subject matter experts. So my doctors, my oncology nurses, and allied health professionals, and even my support groups, they all helped me make the decisions that I needed to make at that time to keep living the life that I wanted to. So that's my advice to other people is remember, you're the CEO of you. It's our role to communicate with our subject matter experts and our team members to help us make those decisions. So we also have another poll here. So what would be most helpful to you? A, talking with others who have breast cancer. B, accessing accurate information to make informed decisions. C, for my care team to ask my opinions about treatment. Or D, for my care team to listen to my feelings, values, and goals.
I think they're all important.
I have to agree with that.
Can we do all of the above?
So, Anne, why don't you talk to us about choosing that treatment?
Sure. Well, so it's a shared decision, of course, as you alluded to. And I the way I think about it is I'm your navigator, but you're the boss in terms of, you're steering the ship. I'm just going to help navigate as best I can when I'm helping a patient deal with making treatment decisions around early or advanced breast cancer. When it's time, you want to go over what are the results of the tests, consider the genetic and genomic testing nuances as appropriate, talk about options, not just the options that you want them to do, but what are the options out there? I think it's really important. I try very hard to tell people what other oncologists might recommend and why I don't recommend it. I just don't just tell someone what I think. I say, I think this, but you might hear this from other people, and here's why I wouldn't do that or I would do that. Or, I can agree completely with what your oncologist locally said because we see a lot of second opinions. I think part of that is assessing benefits and risks, impact on quality of life. If there's a trial, what are the pros and cons of that? And what are the risks? And what are the potential benefits? And then it's about helping the patient to think about what's the best treatment for them. And that might entail not just risks and benefits like, will it make me sick or will it make me tired or will it make me more likely to hear from breast cancer again? But it's also about, or less likely, what's the schedule? What does the treatment entail? What's it going to do to my life? Sometimes we're thinking about treatments in terms of every 3 weeks versus every week. And sometimes that's, 6 of one, half dozen the other in terms of the choice of whether the treatment would work better. And so then it's really about what's easier or harder for you. Some people would prefer a weekly lower dose, and some people come from far and want to get it all done in, in every 3 week regimen. And the other important thing is being, I think, for anybody listening today as a patient or a loved one, it's about understanding what's important to you. So as you hear all these things, if something's coming up in your head and making you, if it's hair loss, that's the most important thing, for example, like we talked about earlier, don't be afraid to say that. Don't be and a good doctor, if they're not feeling like a patient is kind of rolling with it and they're feeling resistant, a good doctor should say, so tell me what's going on? What's making you struggle with this so much? What are the barriers that you're feeling with coming to a good decision? And you can learn a lot by just asking that simple question. As you said, you're the expert on you, and we are the person who's just the expert on breast cancer, but we are getting to know the patient and you. And so you have to guide us through that. Super important.
So, earlier we talked about how there's a vocabulary and a learning curve associated with breast cancer, and it become a little bit overwhelming. So really becomes a little balancing act between really wanting to know everything versus really only wanting to know what's relevant to your own diagnosis. So for some, you may not want to know a little, you may want to know a little at first, and then you may want to know a little bit more as time goes by. The other thing is people have different learning styles. So some people would rather, read educational information or going to websites like coma.org, or, others may just want to talk to somebody one-on-one in real time, like a specialist on our helpline. But to be honest with you, there's really no right or wrong way to balance what you want to know versus what you need to know. And this is really a personal preference. But I think what's the most important here is making sure your healthcare team knows what your treatment goals, worries, and fears, like Rebecca talked about, and how all of this information is vital to your quality of life. So Rebecca, I'll turn this one over to you.
Well, I always say too, knowledge is power, but it is a balancing act. So just like we say, our doctors aren't mind readers, like they don't know how we're feeling or what we want to accomplish if we don't talk to them. So it's really important to tell them also how you feel. Knowing what your test results are and your treatment options are very important. And just as much as your feelings and emotions, it is an emotional time. I don't know that anyone can go through and say, I've had breast cancer and I felt great the whole time. There are emotions that come up, and it's perfectly fine to talk about those. It's just knowing who in your network you can talk to. I actually had a good friend who said, you don't go to the hardware store and buy a donut. You go to the bakery. So you have to know who's in your network and who you can go to for those things, who can support you.
I like that bakery donut analogy. I'm going to use that.
Too. I do too. I agree.
But it's also really important to take care of yourself during the treatment, and try not to be too hard on yourself. I think most patients want to be that superhero, and it's okay. There will be a time for that. So.